Thank you for continuing to learn with us. We will now look at the third part in terms of the changes as introduced in the guidelines. In the previous section, we discussed that DTG is now safe for all patient populations. It is a safer drug, a better side effect profile, fewer drug-drug interactions with your hormonal contraceptives, very potent, a high barrier to resistance, right? So now we are shifting again. We are now saying we now recommend DTG in both first line and second line ART regimens. And if you have patients who are stable on first line or stable on second line ART regimens, you may switch them, or maybe let me use the word transition them to a dolutegravir based regimen. So that is quite empowering, So dolutegravir, it is now recommended as part of a first-line regimen in South Africa, but also as part of a second-line regimen, right? So for first-line is what we all know as TLD, a combination of tenofovir, lamivudine, and dolutegravir. In the second line, zidovudine, lamivudine, and DTG, what we will now call ALD, will be the preferred second-line regimen, right? So this ALD is potent also because it's got a very good drug, zidovudine, but built on a DTG foundation. So with that, we are able to achieve effective viral load suppression after patients have failed first line. It is a well-tolerated regimen. There is a high genetic barrier to resistance because of DTG and very minimal drug interactions with your hormonal contraception. So really, things are getting better for our clients. So, but there is an issue, before we even talk about transitioning patients to DTG, it's very important that you understand something very key about DTG. So the highest risk of a patient developing a dolutegravir resistance is associated with DTG monotherapy, right? The use of dolutegravir on its own. Now, this can happen under two scenarios, at least at a high level. The key message from me to you: obvious monotherapy, where someone, for whatever reason, gave a patient DTG only without the NRTI backbone. So that is probably the worst clinical governance issue that can happen, which we would need to address urgently. Right? That's a monotherapy that's visible to the eye, right? So that's the first part. The second part is a very tricky one, and that is the one you have to be careful of. What I call it, Dr. Mawela calls it clinical monotherapy, and it's not visible to the eye. It requires you to pay attention. It requires your mind, right? So when you look at the prescription, the patient would be taking 3 drugs, right? We would have prescribed 3 drugs. The problem is 1 or 2 of the other drugs, the patient would have already developed mutations or high-level resistance to 1 or 2 of those NRTIs, right? So for DTG to be potent and suppress the viral load in a durable way for the longest time, it always requires at least 1 active NRTI, right? If your NRTI backbone is compromised, that is equivalent to monotherapy, because in those 3 drugs, only 1 drug would be active, which is DTG. Eventually, those type of patients would fail treatment, and it is a clinical treatment failure. It's an iatrogenic treatment failure, which would be caused by me and you, right? So please pay attention to patients who have NRTI resistance. So if someone was taking Truvada, tenofovir with FTC, maybe for PrEP, and they developed HIV and they were taking PrEP for a while, without those 2 drugs being stopped, they might develop resistance to tenofovir. When you start them on ARVs, you start them on tenofovir, lamivudine, and dolutegravir, you find that your tenofovir and lamivudine backbone is already weakened by some mutations. That is clinical monotherapy, and dolutegravir would eventually fail. So that's very important, right? And then some patients, you will start them on ARVs, but they don't tell you that they were previously on some other ARVs, and you need to pay attention. That would make TLD a very weak regimen, right? There are patients who are taking TEE, tenofovir, emtricitabine, and efavirenz, and then suddenly there's a message to say, hey, switch all patients, switch all patients. It's a protocol, and you start switching patients without checking their viral load. If you are doing single drug substitutions, from efavirenz to a dolutegravir-based regimen in a patient who's got a detectable viral load, the viral load is very high. Basically, you're just creating a clinical monotherapy, right? And that those kinds of patients would fail, right? So it's very important that every time you are considering to use dolutegravir, you need to take a proper drug history from your patient, understand the switches that happened previously and the reasons behind the switches. You need to check the viral load currently to say, what is the viral load as I'm trying a switch? Do I need a new regimen rather than just to switch DTG on its own? That is a very important thinking process. And if you feel like you can't trust the NRTI backbone, then it's best to avoid DTG and consider lopinavir, ritonavir for that particular patient. So that is the key message, because you must remember what I said. What I said when we started, I said, number one, we want to transition patients, right, to a dolutegravir-based regimen. So if you have a patient taking a second-line regimen that has lopinavir, ritonavir, and they are suppressed, we prefer that you try and transition them to a DTG-based regimen, right? But before you do that, you need to take proper drug history and understand the kind of regimen your patient is taking. And if they are not taking a zidovudine-based second-line regimen, you shouldn't even be giving them DTG, because there's a possibility that a tenofovir-based regimen, that they've already developed mutations against your NRTI-based regimen. You want to avoid clinical, monotherapy, like I said, right? So how do you apply that now in terms of our guidelines? Which patients can you transition to a DTG-based regimen? So firstly, it must be a patient who is on a standard second-line regimen. So if you have a patient who's taking zidovudine, lamivudine, and lopinavir, ritonavir, and they are virologically suppressed, right? Suppressed, the viral load is undetectable, you may switch them to zidovudine, lamivudine, and dolutegravir, right? So that is very, very, very key. Don't put them on TLD. They would fail treatment, because if someone is taking second line that has AZT, they've probably failed some abacavir or tenofovir-based regimen. They've already developed your K65R type of mutations. So that is very important, right? So in South Africa now, the recommendation is that all patients must be switched, whether you have lopinavir or not. We prefer that the majority of our patients are on a dolutegravir-based regimen, right? In the context where a patient is taking a regimen and there's lopinavir drug shortages, you need to assess if they are on a standard regimen. That's not an issue. You'll just transition lopinavir to DTG. But if they are on a non-standard second-line regimen, like a tenofovir, emtricitabine, and the lopinavir type of regimen, if there's a drug shortage, please don't switch them from lopinavir to DTG. Really, you will be causing more problems for that patient. So you would rather switch them from lopinavir to atazanavir or even juranavir, which is the other protease inhibitors that we have. Just note that juranavir is only available on a named patient basis, and more than half the time, the third-line committee at national would have to be involved. But atazanavir, ritonavir, we now have a combined tablet that has both atazanavir and ritonavir, which can then be used in that instance, right? because here the patient is taking tenofovir as part of a second-line regimen. This regimen is probably compromised, for one reason or the other. So we really don't want to be giving DTG in the context of a non-standard second-line regimen. So if a patient is taking a first-line regimen, tenofovir, emtricitabine, and efavirenz, you can switch them anytime to DTG if they are suppressed, right? But if a patient is taking tenofovir as part of a second-line regimen, that means they previously failed. Please don't switch the lopinavir to DTG. Keep them on lopinavir. If you are running out of stock of lopinavir, transition them to an atazanavir-based ART regimen. So I'm hoping that you have managed to get that message, right? So whether for first line or second line regimen, before you play with the drugs, remember there's a rule. You should never do a single drug substitution, right, where the viral load is more than 1,000, right? You may play with the drugs if the viral load is suppressed. Therefore, the risk of mutations and so on is very low, right? So very important. Once someone has a viral load of more than 1,000, they need to be investigated so that you decide whether you are switching them to a new second-line regimen or what options you have. So some few principles. Principle number one, anytime a viral load is more than 50, it needs to be investigated, right? If it is more than 1,000, we are very concerned, right? So what do you do? So when you measure a viral load, if you make an effort to draw the blood from your patient, you must also make an effort to track the results and act on those results. If the results are more than 50, so the viral load is more than 50 copies, you need to do a thorough assessment to identify problems that you may need to address. You need to assess for adherence. Is your patient missing doses? Are they forgetful? Do they have social support? Have they disclosed to someone at home? Are they being abused by substances? Are they mentally capable of taking care of themselves? All these issues are things that you will deal with under adherence. B for bugs. Does your patient have an infection that may contribute to an increasing viral load level? C for correct dosing. Review the drugs. Is your patient taking a proper regimen, the correct dosing? Check for drug-drug interactions. If your patient is taking TB treatment, make sure that the adjustments have been done as needed. And then E is for early resistance test only when indicated, and we will deal with the indications later on, right? Once you have identified the issues, you then need to implement interventions and then repeat your viral load, right? So usually we say you must repeat it in 3 months' time, and then you can then compare the first and the second viral load. If both viral loads are still more than 1,000, you probably need to consider that your patient has failed ARVs and they probably need a different regimen at that point in time. Right, then the second principle, which I spoke about, you should never change one drug when the viral load is high. Remember, if the viral load is high, it means probably your patient is failing. A failing patient needs a new regimen with at least 2 new drugs. If you are prescribing DTG, you need at least one active NRTI. So you need a new regimen when someone has a high viral load. If a viral load is suppressed, we are generally very happy. The transitions from efavirenz to DTG or from lopinavir to DTG can be done. If the viral load is high, but not higher than 1,000, you still do your assessment to see what's going on and probably repeat the viral load in 2 to 3 months and see if they're not resuppressing. If the viral load is more than 1,000, you do the assessment, the A, B, C, D, E assessment, you implement your interventions for at least 3 months, and then you repeat the viral load and see how things are going, right? If you've got 2 viral loads more than 1,000, you're probably a bit worried that, okay, my patient is probably failing treatment and I need to be looking at other options. So that is quite key, right? So switching between lopinavir and dolutegravir in stable patients, number one, you must determine that the patient is on a standard second line regimen that has zidovudine, lamivudine, and lopinavir. If your patient is taking a different regimen, you should probably keep them on that regimen and not switch them to DTG. So that is very important. So always, as you want to give dolutegravir, check other chronic conditions and other drugs that your patient is taking and pay attention to potential drug-drug interactions. You might be having a diabetic patient who's taking metformin, 850 milligrams 8 hourly. That's way more than 1,000 milligrams, right? So you should not even be considering DTG for those patients, right? And then discuss and empower the patient about potential side effects. For women of childbearing potential, make sure that you discuss risks, encourage family planning, but you'll still give them a choice to say, hey, we want to transition you to DTG. What do you think? Let the patients or the women, be involved in those decisions, right? So that is very, very, very important. Let us not take decisions on our own and give them to patients to implement. No, let it be a collaborative, shared decision-making between ourselves as clinicians and our patients. It always works best like that. So in summary, clients who are taking your first-line regimen, TEE, tenofovir, emtricitabine, efavirenz, may be transitioned through a single drug substitution to DTG if the viral load is suppressed, right? Equally, if you have a patient who's taking a second-line regimen, AZT, lamivudine, and lopinavir, ritonavir, those patients may be eligible for switching, especially if they agree. You may switch them if the viral load is suppressed, right? Never switch a single drug in a failing regimen. So if a patient has a detectable virus in the blood, don't just stop one drug and introduce one drug. You need to probably review and decide if you're going to be giving a new regimen altogether, all right? So lopinavir drug shortages require clients on standard second line, So this is very important. So if your patient is taking, this is a non-standard regimen, right? Tenofovir, emtricitabine, and efavirenz. And lopinavir, ritonavir. This patient might be taking second line, but this is non-standard. So this type of a patient, you should never switch them to DTG. You would rather consider switching them to a atazanavir, ritonavir based regimen if you have issues with your lopinavir, ritonavir. Remember, juranavir, the green one there, is a very good drug, but currently reserved for those patients who are failing a lopinavir, ritonavir as part of the third line ART regimen, right? So I'm hoping we are together. All right, so yeah, so in terms of the key clinical updates on the ARVs, there's two issues. One is the use of DTG for all patient populations, including women who are pregnant and in all trimesters, right? And the recommendation there is that DTG is best. We should continue to empower and educate our patients, encourage family planning, as much as possible, and keep it safe. Then the second part is that if you have a patient who's taking a first-line regimen and they are suppressed, you may consider transitioning them from a TEE, from an efavirenz-based regimen, or even lopinavir-based regimen, if that's a first-line drug, to a DTG regimen. In terms of second line, you can only transition patients who are taking zidovudine, lamivudine, and lopinavir, ritonavir. If the viral load is suppressed, those patients can be transitioned to an ALD regimen, zidovudine, lamivudine, and dolutegravir-based regimen. All right. Do drop us any questions, support@aquatraining.com, so that we are able to reply and help you as much as possible. All right. Thank you very much. We will continue with the next session.